Good afternoon. I'm Dr. Ronald Wheeler. I'm Medical Director for the Diagnostic Center for Disease. I'm also Medical Director of HIFU Centers of America, a company that treats men with high-intensity focused ultrasound, or HIFU. When we talk about anatomy, you can go on and find a YouTube video that will show you the anatomy of the prostate. It'll show you around a little bit the peripheral zone, central zone, and different zones associated, as well as the needle biopsy. We talked a little bit about that in the past. When we talk about biopsy in general, we need to have imaging to do a biopsy. We have to do that. And I would just come out of the gate and tell you this as we start this discussion, that every disease in the human body utilizes imaging to determine what is present. So therefore, whether it's ultrasound imaging for sizing the prostate, which is an excellent tool. Ultrasound will also tell us if it's got stones in the prostate, corpora amylasia, which are basic concretions of secretions and proteins, etc., or other things that we might want to note on ultrasound that we can validate, if you will, from ultrasound. But principally, it's size that matters. We also use ultrasound when we biopsy. That said, the best tool, the most significant, the most sophisticated tool for image is the multiparametric MRI using a 3T magnet without a coil. For men that have ever had it, it feels like a broomstick is stuck up your backside, and that doesn't feel so good. So obviously we wanted to get expertise in this procedure. We have gotten expertise in that procedure, and we no longer need an endorectal coil. So we just need a willing patient with a progressively rising PSA and concern for prostate cancer, maybe by virtue of a 4K score test as an example that you had done. You might have had a MIPS test done. You might have had a PCA3 test done, some other test other than PSA that would tell you that you got a problem with your prostate and you ought to have that interrogated in some manner. So the manner that I suggest that you use, rather than going right in and having the doctor say, well, I've got an opening on Wednesday of this week and it's Monday, and we're ready to do your biopsy. Rather than do that, and because of the ability of biopsies to be done and miss cancers, so basically false negatives. The procedure's done, but the procedure was negative falsely because you have a cancer that was not found. So it makes sense to me when I'm considering using imaging tools that I want to use the best imaging tools possible. So the best tool is an MP MRI. I can tell you that virtually all insurances pay for this, and even if you paid out of your pocket, the cost for an MP MRI 3T should not be more than $500 to $600 cash. So now that we know that, and we're going to take a look at this image right here, this placard that speaks to a 3 Tesla MRI. In this case, it was spectroscopy. Back in the day, in 2006, I was actually a research physician for General Electric. And we were specifically looking at spectroscopy, which speaks to the metabolites of cell function. Things like citrate and choline that are popular, and polyphenols and spermine, etc. As we talk about those things, there's values to that, and we basically get a signal based on the biochemical footprint of that area that's being looked at. And if we see where the choline, as an example, is way out of range compared to the citrate, we would have concern that that individual could have a cancer there. The long and the short is that worldwide, spectroscopy has really never gained a foothold. Excuse me. So instead of a 4-legged stool with the multiparametric or multiple sequences, we have a 3-legged stool. The 3-legged stool basically is a T2 weighted image, and it would be dynamic contrast enhancement and also diffusion weighted imaging. So when we take a look at those 3 sequences, a T2 weighted image is basically a hypointense lesion. A hypointense lesion would be a lesion that's less intense. So therefore it would be darker. Isointense would be what everything would be in a field of view, And hyperintense would be something that would be bright. So when we look at this image right here, so we take a look at this image, this is from 2007. This patient actually is 77 years old, PSA 15.5. So in his particular case, his ultrasound did show some scattered calcification, but we really needed more information on this individual. The reason we needed more information on this patient is because we did not know this patient had 2 previous biopsies done when his PSA was 7.15 and his PSA was 11.5. In both instances, these 10-core to 12-core biopsies noted no evidence of cancer. So this individual comes to me, and at that time, in 07, I was well into my research project looking at MRI as a valid tool diagnostically for prostate cancer. So specifically, I told this individual that, look, if other doctors can't find it with biopsies, there's no reason that I'm going to be any luckier than they will be. And basically, we got to take luck out of this. When you're doing imaging, you want to know, or when you're diagnosing disease, better stated, you want to know all you can know about a disease. And again, every organ in our bodies, except the prostate, utilizes tools like the MP-MRI. So we can't allow prostate to be an orphan drug that urologists make a decision about when we have better medicine available. And in this case, we have better medicine available. So I want to review this scan with you just briefly. This is the view of the prostate. This was back in the day when we used an endorectal coil. That's why the rectal wall is so symmetric. This is magnified, so for greater ease of seeing. This is the left side here, so this makes it left side here, right side here. The prostate I'm tracing right here, that's the prostate. The pubic bone is right here. The normal diastasis of the pubic bone is right here. Muscular structures off to the side. We see some bony structures as well, other than the pubic bone, as well as we look around. That said, so here's the prostate again, and when we looked at this, when I first saw this, I knew exactly where his cancer was located. And the reason I knew where his cancer was located is, I saw this area right here. We identified that as a region of interest. So in this particular individual, I was able to put 2 needles into this side. And I put 2 needles in this side, which were negative, meaning no cancer. On this side, what we found is a Gleason 4+3, 7. I can tell you that without a guide, it would be like playing pin the tail on the donkey, or trying to play darts, and having no clue because you have no dartboard. So we don't want that to happen. We want people to know where those images are. In this case, it's very easily found. This patient was subsequently treated, albeit we waited too long. 15.5 is way too high of a number. We don't want patients coming in with that number. We want patients coming in with 5 as the number, not 15, not 10, 5, or even 4. If somebody's being threatened with a biopsy by a physician, and I say threatened only in this sense, biopsies cause people to be hospitalized up to 8% of the time, according to Johns Hopkins. Beyond that, I would tell you that people can die from a biopsy because people get septic, and ultimately they have septic shock. Septic shock means they die. So there's systems, it's multi-system breakdown, and that's a problem. Beyond that, men are going to bleed from every orifice below the waist for upwards of 2 months. So they need to know that. It's been reported that men have erectile problems and incontinence as well as bowel problems from biopsies. So I would simply say this. The Hippocratic Oath says that we must first do no harm. So when I talk to you as the listener, the viewer, I would tell you, let's start with the MP-MRI. It's very affordable. Let's all get it. If the doc that's testing you at his particular center is not well versed, it's possible that you won't get a good read on it. But if you're using the multi-parametric software and sequences, you will get all the images that we need to look at so we could overread this other individual. I happen to be self-proclaimed, and I'll be self-proclaimed until somebody pushes me off the present position, but I believe that I can read prostates as well as anybody in the world, including the best reading radiologists. I've been challenged in the past. The issue is that I've learned it on the job, if you will, based on my research study with General Electric. So I don't need any more feathers in my cap. I don't need any more asterisks beyond my degree. I'm simply telling you that I'm here to represent yet another opinion because I have the clinical side covered, whereas radiologists typically don't have the clinical side. So as an example, in this case, we did not feel a nodule here, but had we felt a nodule there, I would have told you we would have found something, better stated, we would have found something on the MRI where you feel something on a digital rectal exam. In this particular case, this case brings up another interesting point. This patient actually has two cancers. This is one cancer, and this was targeted. This patient subsequently had high-intensity focused ultrasound. His first procedure failed. Now, I don't know why it failed. I was not associated with his first procedure. He subsequently had a second procedure, and I was a part of that second procedure, and in fact, I was able to cure this fellow. But he has a second cancer, and it sits right here. This is in the anterior part of the prostate right here, so this is all anterior, this is posterior, this is left, this is right. This is the peripheral zone, all this white stuff. So this dark area within the white is a problem. But right up here we have what we call a charcoal sign. And a charcoal sign is almost pathognomonic or indicative of a significant cancer, and that's what this represents here. This would represent a PIRADS 5 if we use the PIRAD system, which basically is Prostate Imaging Reporting and Data System. You'll learn more about PIRADS later. We'll talk about PIRADS later, and I'll make that very understandable for everybody that tunes in to that video when we get that done. Excuse me. So suffice it to say, in this case, I was able to do a cognitive biopsy on this individual. Nowadays, we've advanced. Because of imaging and the doctor's understanding, they've taken the bricks off their laps so they can stand up now and recognize something that's worthy. Doctors are hesitant because they don't want things taken away from themselves. You know, they're proud of what they do. They've been biopsy guys for years. Again, I'm not looking to deny them as long as they have a willing patient that understands all the risks, which we talked about herein. So with that said, what I would say to you, I saw this on MRI, and I was able to put a needle in it. So, that said, that would be something that we would call a targeted biopsy, and we would target, in this case, this particular area here. Now, we'll target it, though, because what we've done is fuse the ultrasound image and the MP-MRI image together. And that fusion would allow us to come up with this area here, such that our needle would go right there and find, in this case, an obvious cancer right here. So that said, beyond that, there's going to be guys like myself that are very good cognitively, and just like I believe it was Bobby Fischer back in the day, or maybe it was the Russian who went up against Big Blue, IBM, a computer, and played a chess match. I believe that I can put my skill set against the fusion, ultrasound, and MP-MRI and beat it at detecting more cancers than it can. So we'll see whether or not that works out down the road, whether I get that challenge academically. But all I can tell you is that I'm up for it, I'm game, I'd be interested. But my point in all this as we go along is that doctors, that once they've learned the fusion part, they now understand the value of the MP-MRI component. I can tell you this, that United Healthcare, as of January of 2015, stated in the diagnosis of prostate cancer that either a biopsy performed or an MP-MRI performed that identifies cancer, either of those two tools, diagnostically, are equally diagnostic of prostate cancer. That's a huge role for the men out there that have no interest in getting a biopsy. I just simply want you to know that. You should consider that. I'm not trying to talk you out of a biopsy, but there are risks associated with the biopsy. If you hear all the risks and the doctor's sincere, he certainly doesn't want you to die from a biopsy procedure, please go through with the biopsy if that's going to make you feel better about the diagnosis. There's nothing wrong with it. It is the standard of care. I believe it's substandard, but it still represents the standard of care. The standard of care has to be multi-parametric MRI, and that will be the standard of care. People that are looking for references for multi-parametric MRI need to go no further than 2011 NIH, an article written by Barris, Turkbay, Choiki, Pinto, and others. You can actually Google that, or if you can't find it, you can give our office a call, or email us at info@mrisusa.com, and send us, obviously you send your email, and we'll send you that article back so that you can read that firsthand. That was a great study done on 46 men who ultimately had radical prostatectomy, but proved in that study that the positive predictive value of an MP-MRI is 98 to 99%. So that's the expected notation around the world. This is noted in London, England, who is one of the it's a bastion, if you will, of educational enthusiasm, academic enthusiasm, and clearly my world that surrounds me is surrounded by imaging, and imaging is really what brings me to the dance. But again, if somebody comes to me and says, will you do a biopsy if I insist on it, the answer would be of course. Once I've labeled all the side effects, in that case I'll go ahead and do what that patient wants, but I will tell them that there's a better way, and that would be MP-MRI. But MP-MRI will guide us on that biopsy in the sense that I'll know where the cancer is located, and I'll subsequently find the cancer, again, virtually all the time. So with that note, I would say, I simply would say that I want you to get away from doctors that are not doing your biopsies based on having a dartboard or having an image to judge by, because otherwise, if they don't do that, it truly is like shooting in the dark. It's like pin the tail on the donkey, and it's really stupid being stupid, and we don't want to be that as doctors. We don't present ourselves that way, so you as patients should not be expected to listen to that and expect that. So with that, I'll bid you adieu. This is an upper level course, so for those guys that have endured this performance here, you may want to watch it again, but give me a call if you got any questions. My website is www.panamhifu.com, and we'll soon have a website up for HIFU Centers of America. So again, with that, I'll say so long for today, and I appreciate your attention. Thank you.